Dr. Choll Kim here from San Diego. I'm at the North American Spine Society meeting, and I'm with Dr. Vivek Babaria. He's a handsome young pain specialist who won the Spine Line 20 under 40. That means that he's under 20, no, I'm kidding, he's under 40, and he's one of the top 20 physicians of the year. So I'm very impressed.
Thank you, sir.
Thank you for being here, and we're going to talk about epidural steroid injections. Is it a Band-Aid, or can it be a long-term fix? Dr. Babaria, what are your thoughts on epidural steroid injections? Because a lot of my patients just want to rush off into surgery and skip the injections because they think it's just a Band-Aid, it's temporary. But what are your thoughts on that?
When we think about the reason why we do an epidural injection, the first thing that I look at is this an acute problem or a chronic problem? In an acute situation, maybe 3 to 6 months, new symptoms of radiating numbness and tingling, an epidural can be more than a Band-Aid. To get to the epidural, you've probably tried medications, some oral steroid, anti-inflammatories, perhaps even some gabapentin. And if those don't really relieve symptoms, then we try to do an epidural. And the goal is to put an anti-inflammatory medicine, a steroid, right near the nerve root or the area we think the pain is coming from. And in that acute situation, if we can change the environment around the nerve and what it feels, we think that it could be more than a Band-Aid.
So would it be fair to say that if the symptoms are due to like an inflammatory problem, like the herniated disc is causing a lot of chemical inflammation, that an epidural steroid injection could decrease the inflammation, have a long-lasting effect?
That is correct.
How frequently do you see that overall? Like my patients ask, what's the likelihood of success long-term, 6 months or more? What would you say that number is roughly?
When I look anecdotally at my data and my patient population, again, if it's a younger patient and a newer problem, in the last 4 years of my practice, I would say at least 30 to 40% of my patients have never come back to do a repeat injection.
That's exactly about what I tell my patients. About 20 to 30% of patients get good long-term relief. That's pretty good considering that the risks are way lower than surgery. So, which brings me to another point. So patients think, A, it's temporary, so they just want to rush off into surgery. I don't think they realize the difference in terms of risk between surgery and an epidural steroid injection, because when I start explaining to them, oh yeah, they're going to stick a big needle inside your back, go into your spinal canal, and bathe the disc and the nerve with the steroid, their eyes open up. So it's not dangerous. Why is it that we do so many of those and we have such little side effects, such little complications?
That's a great topic of discussion. And one of the things I've done in my early career is help publish about the safety of these injections. And one of the big things we've noticed is that it does have to do with the approach and how you do the epidural. One thing that patients should know is that there's 2 ways to approach the epidural space. One way to approach it is called the interlaminar epidural steroid injection. The interlaminar is probably most similar to what women would say, hey, that's the epidural I got when I delivered my babies. In an epidural that's an interlaminar, we use an X-ray, a fluoroscope, and we're guiding a needle precisely into the epidural space. We're delivering medicine, and we're coming out. If you do all the proper techniques for that procedure with guidance and contrast to know exactly where the steroid will go, that is a safe injection.
Yep, because pain specialists, 2 things about pain specialists. Number 1, they have their own specialty boards. So a board-certified pain specialist is usually board-certified in pain and their first residency, either PM&R, anesthesia, or interventional radiology. So the training is very high level, and then everything is done with intraoperative imaging. They didn't use intraoperative imaging back in the day, I guess, but with intraoperative imaging, high-level training, you can get that needle in very safely most of the time.
That is correct.
So that's probably why almost all my patients at least try an epidural steroid injection before surgery, because the risk of surgery versus the risk of an epidural steroid injection it's not even close. Which brings me to another really important point. When I send my patients to my pain specialist, I'm not shifting my care to them. It's still a team approach. And I really rely on my pain colleagues, not only to try to optimize the non-operative care, because that's their expertise, but along the way, help me figure out exactly where the pain generator is, because I don't think patients kind of appreciate that there's like multiple different potential pain generators in your low back. We're not even talking about the neck or the thoracic spine, but just in the low back. There's the facet joints, there's the discs, there's 5 discs, 2 facet joints at each, and with 2 facet joints at each level, so there's multiple pain generators, and some of those have very overlapping symptoms. So you already do this, but a lot of other pain specialists don't do this. I beg my pain specialists to include an anesthetic with the steroid. Do you do that, and do you find that helpful in terms of diagnosis? And how do you coach the patient to deal with that and report back to the surgeon? Or to you?
Yeah, that's a fantastic question. And to preface what I will say, this relationship is so important because every patient should know that we're vested in the best care for you. And again, safety always comes first. What you're asking, doctor, is that the second approach to doing an epidural is called transforaminal. We go in through the side pocket or the keyhole to get as close to the nerve root that we're talking about. When we would do a transforaminal, sometimes on your MRI finding, there's a bulge or the sandwich is thinner and it pushes material out closer to the nerve that's already exited the central canal. In that scenario, an interlaminar would not target the bulge that's pushing against the nerve that's already exited. For that reason, we try to do something called a selective nerve root block, meaning we only want to bathe a specific nerve, and
it's a specific side at a specific level.
Correct. And in that selective nerve root block, we try to use as little medicine as possible, but in an anesthetic scenario where we bathe that nerve and you can report that that goes exactly where I feel my symptoms in my leg or my thigh or my calf, that gives a surgeon a very important clinical information. So in my clinic, we give you a pain diary, and in an anesthetic block, you would be recording what you feel for the next several hours, and you take that sheet back to the surgeon and say, hey, this is the relief or symptoms relief I got during the next several hours of doing this transforaminal that was selective.
Okay, so you know the next award is going to be the 20 under 50. So you got 10 years to convince my colleagues in Southern California to do that, because here's what I noticed. When I operate on patients that have a positive diagnostic response, so in other words, when they get the anesthetic like you get at the dentist office, during the first 4 hours while it's working, their pain goes away. And when the anesthetic wears off, the pain slowly comes back. And unfortunately, the steroid doesn't kick in long term. That's a positive diagnostic injection without a therapeutic response. If I operate on that patient, the likelihood of success is sky high. Every once in a while, I'll have to operate on a patient that has a negative diagnostic injection. Mm-hmm. We do the targeted injection, and they don't notice any difference in their symptoms with the anesthetic during that diagnostic phase. And for a variety of reasons, it doesn't happen very often, but when I operate on that patient, the likelihood of success is much, much lower. Okay. So not only are we trying to get patients better non-operatively, but along the way, if I don't have a good pain colleague helping me with that patient, the results of my surgery can be vastly different. Let's talk about the difference between an interlaminar and a transforaminal. Because what I noticed is that most patients, their first injection is interlaminar. Why is that? And what's the benefit of doing the interlaminar injection? And what's the drawbacks compared to the transforaminal?
This is one of the great debates in interventional pain management. Personally, my ethos is to follow the pathology and what the patient is feeling. So depending on where your disc herniation is, if it was a central herniation or a paracentral herniation and it's really bathing the central canal, it would make more sense to me to attempt an interlaminar because, again, we're addressing the pathology at hand.
Because there's more volume in an interlaminar. The interlaminar kind of goes everywhere and all the way around.
When I talk to my patients about this injection, I use an analogy of the ocean and the river. If you want to bathe the ocean, you go down into the interlaminar space With about 8 to 10 cc's of fluid, I can cover the entire lumbar spinal column with anterior and posterior flow of the medication. So under live contrast, we literally see if the medicine went above the bulge or below the bulge. And if it got stuck, I could then report that to my surgeon. I couldn't get medicine past a very tight stenosis.
That makes a lot of sense. And the interlaminar is just more about just treating the patient. When you start doing transforaminals, it's much more targeted, so it's both therapeutic and diagnostic.
And diagnostics, yeah. So if I had to bathe the river, it's again a different approach. We're going to a very specific nerve, and we expect that to go down a specific track. So I say if you want to feel good, we usually try to do the epidural in the interlaminar space. If we want to try to feel good and be diagnostic, we would do a transforaminal.
I wish I would have met you 20 years ago. If I was going to get an epidural steroid injection, give me an idea of what my day would be like. I mean, is it painful? Is it, do I have to take a week off work? Describe to me what a typical epidural steroid injection procedure looks like from the patient's perspective.
You got it, sir. Every patient should know that an epidural injection is probably one of the most common things an interventional pain doctor does. And in my early career, in 5 years of practice, I've probably performed over 12 to 15,000 injections, of which half of them would be epidurals, at least.
Wow.
And so it's a very common thing that we do. That doesn't mean for you as a patient, it's the first time you're going through this experience. Regardless of those numbers I just said, I would say that less than 20% of patients even ask for anesthesia or some type of twilight because of how easy this can be. Again, I have the repetition, but I always want to treat the patient like it's their first time. And what we do in our clinic is that there's two ways to do this. You could do it in an office-based setting, or you can do it in the surgery center.
But you always have intraoperative imaging.
You always have to have intraoperative. It's the only way to do this safely. So on the day where you choose not to have any anesthesia, you would come in, we would apply a local anesthetic like the dentist on the skin. We would apply anesthetic to our target area. Then we would, I call it a medicine introducing device instead of a needle to try to take
before
away
you stick
some
the
of the
big long needle in, you're anesthetizing the tract.
The entire tract.
That's very nice of you.
And then in my fellowship, Dr. Furman called it the medicine delivery device. So we're not even trying to thinking about that long needle. It's like a tool to make sure the medicine goes where it needs to go. And it's a different tool for interlaminar and transforaminal, different type of a needle, but the entire tract is bathed. And then once we get to our target to prove its safety, we use live contrast or omnipaque. So that's one of the risk questions we ask every patient before we even do it is, do you have any allergies to contrast or shellfish because of the way that contrast is made?
But that's a dye?
It's a dye, yes.
Tells you where the medicine's going to go in the epidural space, because we want to know exactly where everything's going.
Yes,
and that makes a lot of sense.
And that's an important question because the most important risk that can come from an epidural is if the medicine goes into the bloodstream. And so when you do the live contrast, you're proving to yourself that when I inject this medicine, it will not penetrate into the blood. And that's where the major risks come from doing the epidural, is that if you use something called a particulate steroid, and it goes into the bloodstream, that can then track back to the brain.
It's funny because you probably do an entire procedure in like 10 minutes. But from the patient's perspective, they're there for a while. So they usually come to the procedure suite early, and then they go into the procedure, like the OR basically. How long are they in the OR overall? Not just your part, but like when they're in that cold room with all the lights all by themselves?
Great question. Again, in the two scenarios, if we're doing it in a surgery center or ambulatory surgery center, I say the patient check-in process and check-out process is longer than actual OR time. To do this injection in the OR, about 5 to 10 minutes, 5 minutes of prepping and charting, and then the check-in, check-out, blood vital signs, and the paperwork usually take longer. So in my surgery center, my patients probably are there for an hour from start to finish. If we did it in a clinic-based setting, I have them come 15 minutes before their injection, do the injection vital signs, so maybe 30 to 45 minutes in a clinic-based setting.
And the patients have to come with a responsible adult to drive them there and back, right?
Well, again, that depends. If it's a local injection, I have a majority of my patients drive themselves to and from the injection.
That is really helpful. And do they have to take time off work? How long do they have to stay away from sports and things like that? What are the restrictions after an injection?
Great question, Doc. It really depends. Many times I have patients who want to go back to work, and they're more than capable if they've done it under local, meaning no anesthesia at all. If you had taken any medicine like a Xanax or an Ambien, or you've done any type of anesthesia, you cannot go back to work and you would need a driver. But again, I said earlier, 70 to 80% of my patients go back to work the same day.
Wow. And you know what I love is that we're always trying to have like a general sense of what everybody's like, but at least in my practice, there's so much customization and individualization because spine patients are still quite unique. I'm not a knee or joint surgeon, but I suspect they don't have that problem as much because it's a much more straightforward problem. It's just one joint, but with the spine, multiple levels, multiple sides, neck, thoracic spine, low back. I love that you're customizing things.
I wanted to add one thing. One of the biggest misconceptions that I get is that, hey doc, my pain's down the leg, so why are you injecting my back? Because I don't have any back pain. And I think that's one of the big things in terms of our communication and the patient education, is that when you have the need for an epidural, it's not because you have back pain. We're doing this epidural because there is something going down the leg. But that's one of the biggest things I get asked is like, why are you injecting up here? My problem's down here. Yeah. And that was one big gap, I think, in a patient understanding of how an epidural works.
I mean, there's so much information for everything that I can see how patients get very overwhelmed. So that's why we're here. If you wanted to just summarize the key points about epidural steroid injections from a patient's perspective, what would that be?
Number one, epidurals are very safe injections if done with all the proper training and equipment. Number two, epidural injections can be done under local, meaning you don't need anesthesia for this procedure. And number three, epidurals are part of the care paradigm that help us be the best care providers for you.
Wonderful. Thank you very much.
Thank you.